Good morning, ladies and gentlemen. This afternoon I will indeed present the full data set of MAGRIT, a double-blind randomized placebo-controlled phase 3 study to assess the safety of MAGE-A3 cancer immunotherapy as adjuvant treatment in patients with resected MAGE-A3 positive non-small cell lung cancer. And the trial rationale here is twofold. One, it's a disease setting where improvement of cure rates is hard to achieve. And two, it's a very well tolerated and promising treatment approach. So first, operated lung cancer patients, about 40% of these patients are cured after surgery. And in 2004, a large adjuvant chemotherapy study came out, brought adjuvant chemotherapy in our practice, and with that practice, the cure rate went up to 45%, but postoperative chemotherapy in lung cancer patients sometimes has important side effects. On the graph you see the difference. The hazard ratio between surgery alone, surgery plus chemotherapy was 0.86. And since 2004, this is 10 years ago now, there was no progress. The therapy MAGE-A3 cancer immunotherapy. MAGE-A3 is a protein that you find on the tumor cells, on the lung cancer tumor cells. You don't find it in normal tissues, so therefore it's a selective and suitable target. We have seen activity with this therapy in metastatic melanoma, and there was a promising activity in resected lung cancer patients. That's the second graph, where patients having the vaccine after surgery did better than the others with a hazard ratio of 0.78. It's very well tolerated as a vaccine immunotherapy, and there was a sign of a predictive biomarker, a gene signature that was first seen in melanoma patients and then also confirmed in lung cancer patients. So this was the reason for MAGRIT. And how did this trial run? Well, adjuvant trials in lung cancer are always to test the study hypothesis in a definitive way, and this means large numbers, long duration. So in total for this study, we screened nearly 14,000 post-surgical patients for expression of MAGE-A3. Valid samples were nearly 13,000, and as expected, the protein, the antigen is there in about 1/3 of the patients, 4,210. And then in the randomization phase, about 1,500 patients had, it's a 2-to-1 randomization, about 1,500 patients had MAGE-A3 cancer immunotherapy, and about 750 had placebo in exactly the same schedule. So the patients first had their standard therapy, which is surgery or surgery plus chemotherapy for some, and then they had randomization. And as you can imagine, with these numbers, this was a global study with involvement of both Asia-Pacific, Europe, and both Americas. So what are the main results? The main results are a definitive but disappointing answer for patients and investigators. Because looking at the disease-free survival, which was the primary endpoint, the median disease-free survival was 60 months in the MAGE-A3 arm and 57.9 months in the control, in the placebo arm. And clearly these curves are very close to one another, and this is not a significant difference. So what are the implications of this large study? Well, it's hard to achieve any progress for operated lung cancer patients from where we are now. Adjuvant MAGE-A3 cancer immunotherapy did not improve outcome compared to the standard of care, which is surgery and adjuvant chemotherapy in some patients. And so since 2004, there is a failure to improve outcome in this setting, and we have seen other failures in recent years, personalized chemotherapy, use of EGFR blockers in this setting. In the absence of 10 years of progress, I think this promising strategy needed formal testing, and this led to this largest therapeutic trial ever done in lung cancer. It was confirmed that vaccination strategies have very mild side effects, so patients were not harmed in this study. It gave us a detailed prospective database on global treatment patterns for these patients. Modern thoracic surgery, only 15% of the patients had the total lung removed, and that's a kind of a quality indicator for good modern thoracic surgery. Modern adjuvant chemotherapy patterns, and I think the study sets a benchmark for future work. Actually, the expected 5-year survival rate in this study for these patients will be above 50%. It's also a source for further analysis on what we may do in the future. Second implication, it's a definitive test of therapeutic vaccination with current technology in lung cancer. It's the largest vaccination trial ever done in lung cancer. I think it's the appropriate setting after surgery. In order to increase cure rates, you want to eliminate minimal remaining tumor cells after surgery. And the study had adequate design and power. What about further immunotherapy development in lung cancer? Then I think we need better understanding of mechanisms. And very important there, I think that's crucial to this study, is that lung cancer has a very immunosuppressive environment. And what does this mean? It means the strategies like MAGE-A3 immunotherapy, they do create effective soldiers. And these are antibodies that can kill tumor cells, T lymphocytes that can kill tumor cells. But the question is, do the soldiers act in the battlefield? And what I mean by that, these effective immune tools that you create, once they come in the tumor, they either do not enter the tumor or they are paralyzed when they are in the tumor. So the soldiers are there, but probably they don't act in the battlefield. And for that reason, checkpoint inhibitors, which are in the middle of our discussion also at this meeting, are perhaps of major interest because these are the agents that try to reverse that environment in the battlefield. And so for future progress, I think combination of vaccination and checkpoint inhibition may be of major interest. Thank you.